is very common. Almost all of you know more than me because arguably I'm just a home dialysis person. And so the presentation on this is supposed to be in a manner in which I can somehow anchor to my favorite topic back, which is obviously that talk to your patients. Always talk to your patient to figure out what you can do. And how do you do that better? We are going to use the vascular access as an example for that. Two things. One is, while I'll talk about mortality as the primary outcome, almost everything else in vascular access is connected and follows the same theme. So just remember that. And the second is, there is no way, considering that vascular access and hemodialysis are part of a major sort of work that we do, almost close to 60% of the nephrologist work, there is no way I can cover everything. I also am not asserting an opinion of, I'm not asserting a confident opinion of what my conclusion is going to be. What I'm trying to tell you is, we messed up, we tried to correct it, and we are continuing to mess up a little bit, and there needs to be some need for correction. Okay, so this is, previously we were on this side, now we are on this side, and there is a need to come in the Goldilocks. So that's sort of a rough outline through which I'll go through this. The first part of the talk is, before I go ahead, I do want to acknowledge everybody who works with me and the entire team who does a variety of different things. The people who are instrumental in presenting in this particular talk are highlighted in the blue ones. The rest of the people and the funding and the team is mentioned for your this thing. I have no conflict of interest, financial at least, so other than the fact that I like home dialysis. We are going to do three things. The first section of this is going to be for nephrology fellows benefit or the trainees benefit, partly because, and this is where you date yourself. When I was training, people who presented history of anything were very old people. At least I thought so. And then I realized that in order to present this topic, I have to give you a little bit of history. And so a couple of days back, I realized that whether I look old or not, it looks like I'm getting old. So that is one. So that's the first one we are going to do. We will discuss how the outcomes and access connect to each other, and we will discuss what the residual need with the current understanding is. So, timeline of hemodialysis. And again, since I was doing history, I just thought, let me just make it reasonable for you. So the first mention is in 1800, where somebody said, and there is something called a Bakerian lecture, or it's a Bakerian lecture that happens in Royal Society. But this particular principles of osmosis were described at that time. This is where the first modern sort of quote unquote dialysis started. And I think if you attended my physiological lectures, you know dialysis is the process of diffusion and convection. This is where the whole diffusion process started, or at least the description of the term. Thomas Graham also coined the term dialysis. And then for next 60 years, most of the people didn't do anything. And then somewhere in the vicinity of First World War onwards, there were animal studies. The initial chemists used dialysis procedure to sort of take things out of animal body. And they were just chemical, and they didn't realize that there was an implication on human kidney failure. But then subsequently in 1924, George Haas was the first guy who started dialysis. This is that particular picture. Say for what it wants, there is a patient, there is a dialysis happening, and there are tubes flowing around. Subsequently, people realize that you can do dialysis to keep the person alive. Obviously, this is usually all in AKI, most of them traumatic. There is no real actual dialysis going on for any duration. But they realize that you have to get the blood out of the body. This is all hemodialysis, by the way. I'm not talking about PD today. And so they had to get the blood out. And since they can't really get the blood out, they had to use heart as the pump. So they would get the blood out of heart from an artery, and then return it back. And just look at all those circuits and imagine how many complications it must have been. I have in my life done CAVHD, and I have put this stent, and I'm telling you, even with normal blood pressure, it's very difficult to maintain a blood flow over 100, 110, 150. So imagine and this was with an artificial pump in addition to CAVHD, and we still could maintain only that. So what must have happened over there? And then they used to get it through these sort of glass and metal trocars. And then Wilhelm Kolff was the first guy who described and actually made a machine. This guy was in Netherlands. And then subsequently, an English doctor modified a little bit of that. But the main dialysis crux that came was Kolff then sent the machine to Brigham and Women's Hospital. And Brigham and Women's Hospital was the one which made the actual modification in the machine and made it usable for traditional patients. So from 47 to 62, this is where the dialysis technology as a viable AKI treating technology started getting established. Again, just remember all throughout this, it was all femoral access, okay? And then subsequently, and I don't know how many of you have seen this dialyzer. I'm assuming that Brigham still has many of the Institute Northeast have these in their museum, dialysis museum. This is the Keels dialyzer. We used to have it. When I trained in nephrology in India, KM Hospital, we did first dialysis in 1967, 68. And we used to use Keel machine at those times. We had it in our museum. You have the large cellophane membranes, and then you fix it between the two plates, and the blood will run between those two plates. It was a fun thing. My professor had actually done that dialysis. He had set up the machine and everything. So it was quite. This is not that far, but it's like a two generation back situation. And after that, it became this made it possible more likely than not to do dialysis in ESRD. And that's when in 1960s, we sort of realized that, and this is going behind this, but we realized that we needed to have some sort of a more permanent access rather than each dialysis. You do a surgery and establish a new access. So this is basically the Quinton Scribner shunt. There were like two PTFE cannula. You'll put one on the arterial side, one on the venous side, and then take this tube in between. And then you connect the tube. And once the dialysis is finished, you connect that tube and send the patient home or wherever he goes or she goes. It was largely he. And then once they go and they come back, you remove this and everything works. And then you do the next dialysis, put the new ones in, those PTFE cannulas in. I have used this part. We used to do dialysis in kids in India. And I had once a hypocomplimentinemic HUS. And at the time, I'm talking about 90s, we didn't have a pediatric size double lumen catheter. And so we had to, we had it, but we didn't have tunnel one. And I think at certain point, once we had run enough relapses of HUS, we had to sort of put this in. The child survived for 2 years. We didn't know at that time there is something called hypocomplimentinemic HUS, which keeps on recurring again and again. We used to follow this person or this kid every so often. And then one day we just heard that he died because he used to come from about 1,000 miles away to us. And one day we just realized that he died and because he couldn't reach to the dialysis unit in time. What happened here? Okay. Anyway, so going forward from there, after that, what we know as dialysis came, hollow fiber dialyzer, the fistulas and the fistulas iteration, and so on and so forth. I'm not going to go through this particular second timeline. This is how actual regulations around dialysis develop. But essentially, what I'm trying to say is that if you see these early things, we did a lot of emotional blackmailing of society to sort of say that, hey, you can't let people who can potentially be saved die. lack of money is not, or resources is not a reason where a person needs to die. So, and a lot of these documentaries and etc. did those things. It was quite discussed. And then eventually what ended up happening was in 1973, we got this dialysis approved as a part of an amendment to some other bill. So everybody who hates politics, that there are these amendments and unnecessary expenditure that government does. Remember, your entire livelihood is dependent on a bill that was not designed for dialysis. It was just Social Security amendment, and dialysis was just an attachment to some other expenditure that was going on. And this was the question that they raised. But essentially what they said is that, guys, approve us this money, because if you don't approve us, we can have potentially usable a earning or sort of productive member of society will die. And by the way, since dialysis is so difficult, we are not expecting that there are going to be many people on dialysis. So just approve this. In fact, what they said was that it would be and their estimation was about 10,000 people. And they said that because at the time about 40% were doing home dialysis, that this is largely going to be people are not going to come to us. They're just going to be at home and doing dialysis. And we are only dialyzing healthy people. This is the projected cost. What ended up happening, as soon as anything gets approved in government, that people start using it. And then we realized within 10 years, we had cost where the end of 80s, the cost had gone up 10 times. The number of people on dialysis had gone up 10 times, 100,000. And since then, you know all the story. And what has happened simultaneously is these are the things that are happening. You are dialyzing more and more and more and more complex people. These all will connect at some point to our vascular access. So as these happen, they say, who decides for dialysis? And traditionally, physicians decide everything. So they left it to physicians as to which dialysis that's going to happen. The problem was that as the physicians were deciding, the home dialysis kept on going down and the hemodialysis kept on rising. And you guys all know this. I don't have to tell you this. There are about 600,000 people on dialysis, about 120 to 130 every year starting dialysis, 90% of them starting hemodialysis. And there comes our primary problem. We need somehow to do hemodialysis. This is 1993. USRDS was also a little bit primitive at the time. And so this is a subset of USRDS. USRDS couldn't collect all data in all people and analyze it. So they had to create like these samples all the time. And so this is wave one is one of those studies, very classically sort of a reference. And one of the findings over there is that what type of access people are using. Remember, this is prevalent and incident access. You can see about 60% or 40 to 60% of people, incident and prevalent, were using graph, AV graph. About 20% were using AVF. Their definition of incident and prevalent was anybody less than 1 year is incident, anybody more than 1 year is prevalent. Today, the definition of incident is the new start, and anything beyond that is prevalent, which is the correct definition. And about 40% would have an attempted vascular access before it. Just remember this, we will keep anchoring back to this as to how much we have changed or improved. Okay. By mid-90s, we realized a bunch of things, and I'm not going to show you the data on that. We realized that all three access at the time, fistula, which came up in 1960s early, graft that came up in late 60s, early 70s, and catheter that came up in 1980s. All three can provide a reasonable vascular access. But the more you go from a natural body connection to non-natural or synthetic membrane, PTFE, which has been accepted from that time till now, the more you have complication. And this is a common thing. And you can see the proximal complication like thrombosis or closure of fistula and so on and so forth. You can do a distal intermediate like infection, hospitalization, or you can do longer term complication like mortality or other hospitalization. All of these are more as you go from natural to synthetic membrane. And this was well established at the time. So in 1997, we formed the first guidelines on vascular access. Now, people in home dialysis area have a lot of complaint against these people. This was the same body that also established the home dialysis adequacy guideline. And there are a bunch of things that happen in this guideline, which in retrospect, we thought could have been done differently. But one of the things that they did, and they defined an ideal access, which even today stays the same, the one that has adequate rate of flow, long use, and low rate of complication. It's always good to define or anything very loosely so that you are never wrong. But in the process, they ended up putting these sort of guidelines. Create a fistula, that's your first preference, graft, second preference, and catheter is the last preference or should be discouraged, okay? And then what they kept on doing is that they overpromised on the side of benefit. Excellent patency. This is just straight out of their verbatim. I'm not changing anything. Excellent patency with AVF, lower complication rate, lower morbidity, and improved performance over time. The only thing is that it might take a little bit time. So send people for fistula creation a little bit earlier than this. There was no real thought here as to what type of dialysis you should do, who should decide this, or any of those things. So they basically, their sort of end result was that let's increase fistula, let's monitor how it goes, and do this early now. And that basically was there for next almost 15 years or 20 years, okay? Over that 15 years, what we were trying to do is we were trying to, we as a fraternity thought we have the truth. And we were trying to implement this truth to the best of our ability such that we can achieve that particular stated goal. So what happened? Well, as we were doing, we were finding new data and we were sort of putting it together. So obviously this is early data and there are like 20 such papers. I'm just going to show one for each example, which is if you have AVF compared to AVG or CVC, you survive longer. The survival is better. At any given time, you can see the hazard ratio of odds of survival, and they are significantly higher with fistula compared to graft compared to CVC. And this was a recurring theme through multiple different database analysis and cohort studies around late 90s, early 2000. And so what people were trying is, and I told you, I'm talking about mortality, but it is going to be most of the complications that I sort of indicated earlier. And so what people were saying is that if you have incident vascular access that we think is a better one, that you will have better ESKD outcomes. For practical purpose, we are just going to stay on survival, okay? And so what did we do? Well, we made a bunch of mandates. We had a bunch of quality improvement. This is a national level quality improvement project. And what did they do? They said, we are going to give you a structured step 1, step 2, step 3, step 4, all the way to step 13. We are going to give you a structured idea that how you can make sure that the person has fistula. These were the goals. And they said 50% of incident and 40% of prevalent vascular access should be AVF. I'm not sure why they flipped. I really didn't, and I couldn't find it, why they flipped it, why prevalent is lower. That I didn't understand, but the 50% they wanted incident to be fistula. Anybody knows what is today's incident fistula rate, fellows? It's still below 20%, okay? So just so that you know. And the following NK-DOKI guideline or NK-DOKI guideline, my apologies. By this time, it had changed the name. I have copied and pasted. So I acknowledge this mistake happening even for 2021, where this is going to say NK-DOKI guidelines. I think it is now just called KDOKI. Anyway, But they said, we wholeheartedly agree with that National Vascular Access Initiative, which was by that time was renamed as Fistula First Initiative in 2005. And they said the most important goal is to make AVF. Just keep making AVF. And when you do these things, what do? You are telling people across the field that you have a target, that you have to achieve these targets. And that not achieving these targets means you are providing poorer quality of care. Okay? So what they are trying to say is that we know what's good. Do this. If you're unable to achieve, that's poor quality of care. Okay? And again, the language is the same, so I don't want to go about that. But in the 2006 guidelines, the first time they recognized that not everybody needs fistula. So you can't have a guideline which tells everybody below 20 or below 30 to go for fistula, because there are people who are never going to do hemodialysis. So they recognize that, hey, at least decide what you are doing. Okay. Now, in all fairness, I think even after recognizing this and staying outside, this was outside their field, they said including transplantation, which is a crazy thing to put there, considering that we have never had preemptive transplantation rate of more than 2.5% to 3%. Unless we have some sort of viable option to have that is a problem. And I can tell you from an alternate side, there are studies even today being done where they ask for KRT preferences and they ask for transplantation as a legitimate preference to dialysis. Since transplantation is preemptive transplantation is largely a feasibility issue, it should be separately evaluated. It cannot be evaluated with your entire population because that's not a reasonable KRT estimation. And about a third to 40% of the people that you ask will say, I want to do transplant. For the last 40 years, it's never been more than 2.5%. So what are these people going to do? So there is a legitimate problem in these evaluations. Anyway, again, they had a rationale, but the bottom line is what you can't read is among everything we have evaluated, fistula is the closest to this, okay? You know from my tone and my entire, this thing, it's not neutral, it's fairly biased tone that I think that was wrong, right? And now we will see why it was wrong. But their assumption was that if you improve the quality of care, you can improve incident vascular access, and that can improve your survival. That is the assumption under which they were progressing. What happened? Well, the Vascular Access Initiative, subsequently renamed Fistula Plus, Breakthrough Initiative, eventually got renamed as Fistula First Catheter Last Initiative after they recognized that AVG is still a viable option. And then, so all of these progressed over 10 years, 2003 to the last one came about 2012, where the QIP, and in that quality improvement process of performance measures, they suggested that basically, if you don't, by that time, they started introducing a language. If you don't achieve that rate, remember by this time, Affordable Care Act was here, the bundling was already there. So they said, if you don't achieve this target, here are penalties associated with your reimbursement. So now all of a sudden it went from, hey, do it. You haven't done it, well, your penalty here. So this is what the regulations were doing. And what did it achieve? Well, you see this 93, we had about 40 to 60% graft, okay? Your AVF rate went up substantially. By 2011, it's up almost 60%. By 2015, it crossed the target of 66%. It was revised, the 50%, 40% target was revised in 2007 to 60%, and it also exceeded that. So now prevalent access was more than 60, where 2/3 were having prevalent access. The CVC went down and AVG went substantially down. Okay, so arguably what their hypothesis was that if you improve the quality of care, it improves the outcome, right? And so now their next estimation was that if you create guidelines, and we all know this, guidelines improve the societal or practice behavior, which can then cause improvement in outcome. This is the reason almost every talk that we see, the fellows are presenting, there is like, hey, KDIGO says this. We don't know how much of that is evidence-based, how much of that is opinion-based, but KDIGO says this, right? And that is why guidelines are very powerful. So the notion was that guidelines improve quality of care, which improves incident vascular access, which improves survival. Now, in the next few slides, we are going to see some data that argue, is this really true? Okay. So guidelines did improve prevalent vascular access, but the incident vascular access never improved. You still had about less than 20% of incident vascular access being AVF or AVG. Okay. And about 80% were CVC. This is almost the same as 1993, except for the fact the incident was defined differently. So I can't really tell you how many people reported at that time with AVF or AVG. So after almost 20-something years of effort, we have roughly the same situation for incident vascular access. The prevalent vascular access were getting better. Part of this is dialysis is a very methodical process. There are LDOs. You just have to twist the arm of 3 people to get the whole 70% of your population being compliant. There are 3 large LDOs which take care of about 70% of the population, right? So what I'm trying to say is that it did increase this, but incident never increased. The second is, and my apologies, it doesn't look, but just see this. These are the primary patency rate of your fistulas. This is the meta-analysis. This is from 2014. So the studies are up to that time. The primary failure rates of fistula is somewhere around 30 to 40%, which means you create a fistula and about a third of them will never mature. The primary patency or the patency functionality at 1 year is about 60%. You create a fistula, at 1 year, only 60% are working. And at 2 years, it's about 45%. So what I'm trying to say is that 30% never work, around 60 to 70% work, but out of them, at 1 year, it's only about 60%. And by 2 years, it's only less than half work. So the longevity of vascular accelerated fistula is not that good. And then there are assisted and unassisted patency rate. So we will the right-hand side ones are assisted patency rate. They are real-world patency rate. That causes multiple procedures, which causes costs. And there are these health economy studies. And I don't know how many of you can understand, but I can't understand health economy study. So I'm just going to pick up and say that they said this is a very high risk, repeated procedure requiring this thing, that a fistula first as an option is not a reasonable option for everybody. You have to select who the fistula first option is good. And then there are these outcome studies which say that if you attempt fistula, you have better outcome, not just CVC versus AVC fistula. We saw the study that compared to CVC, fistulas have better outcome. But then studies started coming that even if you attempt a fistula, you have better outcome. Now, that doesn't make sense. If you attempt but fail, why should it improve outcome? It largely does so because you are a doctor. You're quite knowledgeable. No matter what regulations say, you're not going to send your sick people for fistula creation. You will, at the minimum, you will make sure that your patient doesn't get hurt, which means that as you are referring people with these guidelines and regulation, you are selecting, knowing or unknowingly in your mind, the best people who are likely to get success, meaning thereby the people with the lower amount of comorbidity burden compared to people with the high comorbidity. So that's the reason. So this particular concept started appearing. And this concept became really nicely demonstrable in this particular study. So in this study, this is a Canadian study, and this basically changed this I must applaud the authors on this because they were very measured, even though they were proving something. They did a prospective evaluation of 2,300 people, advanced CKD, and they just prospectively observed them. Out of these 2,300, 21% had a pre-dialysis fistula attempt, 80% didn't. Out of these 21%, only 2/3 started dialysis with a functioning fistula, 1/3 didn't. And out of these 1/3 that didn't, only half of them ever got fistula working or used that particular fistula. Meaning thereby, if you see out of 2,300 advanced CKD patients who started dialysis, who were prospectively followed, these are not the people who died. There is no death here. These are all people who went on to require dialysis. Death was excluded already. So amongst the 2,300 advanced CKD people who are going to start dialysis, only 17% had fistula creation. Your population selection is 1 in 6. It's quite likely that you are selecting the best of the best. And then say, who didn't get attempts? And so then there are these type of things. You don't have to actually read it. I doubt you can read it. But essentially for every comorbidity, the higher the comorbidity, the less the attempt of fistula. And then basically at age, this thing, whether no attempt had more mortality than attempted one. So essentially what this sort of shows is that as we practice, as we make ethical practice decision, we don't necessarily restrict ourselves to guideline or adhere to guideline because we take decisions which are in best interest of patient. And I think they also sort of demonstrated nicely by stratified analysis that people with more than 65 years of age, the fistula was not as useful. Now, that's their cohort, their sort of conclusion. And so they were saying that there is no way I can control, and this is, I'm shooting myself in the foot because I'm going to show you something where I'm saying, no, that's not entirely true. But what I'm trying to say is that, and this is the reason why I applaud the authors, is that they say, as we are showing you benefit of fistula, we are telling you there is no way we could have controlled this enough to make a firm recommendation. There are a lot of patient-related problems and physician selection problems that we can't clean up in this. Anyway, so going back to our model, which is guidelines increase quality of care, which increases vascular access, which increases survival, has a problem because comorbidities, and I'm saying comorbidities, but just assume it as a fixed and non-fixed.
So in the previous slide, was there any difference in the mortality between the different groups?
Yeah. I think it's difficult to read from here, but this is like not attempted fistula mortality, attempted fistula mortality less than 65, more than 65. They also have graphs on this thing, and this is just a stratified analysis by age.
And was there any difference between those who they attempted a fistula and those with successful fistula?
That I showed you that one in the previous one, I don't think they had enough numbers to do that. Okay, so the problem in our theory, or whatever the prescribed theory, was that comorbidity affect these things, and they are not controlled in these guidelines. The problem, and by comorbidity I mean everything, okay, everything that you can put in the mix. Patient, provider, and system level comorbidities, because I didn't know how to say that without using the word comorbidity, but it's quite possible there may be an access related issue, barriers basically, let's call it that way. But then the barriers really doesn't put patient in perspective, so I said comorbidity. So, but there could be a patient, provider, or system level barriers or adjustment that affect these outcomes. And the problem is the guidelines don't take care of this. So what should we do? When that happens, if you follow guidelines, as we saw previously for the cost of care, you can reduce the quality of care, not improve the quality of care. Following guideline in people in whom fistula is not likely to survive or is likely to fail can reduce the concept of quality of care. We all understand that. Whether we can measure it or not, we don't know, but it can reduce the quality of care. And if that quality of care is reduced, it has a variable impact on vascular access. You can butcher a fistula into somebody in whom it should have never been attempted. Does that mean that you really are benefiting patient mortality? So it can have variable impact on the rates of incident vascular access and survival. And it's very difficult to measure this. Well, in order to address this, you probably need to adjust your guidelines to the things that influence those things. And so there should be comorbidity adjusted guidelines. And that's what came in 2019-20. And this is their attempt to do this thing. And you don't have to do. Do you know why I put this slide? I said that they made it complicated. They went all out to say, first, figure out what your patient wants to do. Don't start with fistula. First thing you need to do is something called PLAN. I mean, the acronym just says it all. It actually is patient life and something. But it's what is? Yeah. So, so they say don't talk about fistula when you have low GFR. Talk about the plan, patient life action plan. Decide what patient wants, what is needed, all of this. Achieve these by shared decision making. And then those people who want hemodialysis and for whom hemodialysis is appropriate, we will tell you how should we approach that. So every guideline comes up with their own fantastic catchy word. They say right access, right patient, right time, right reasons. Okay, fair enough. They say there are studies which show lower mortality with fistula, but they are not good studies. So we are showing you what are the studies we looked at, and we are telling you that's not good studies. And so they've made these 8 guidelines for incident vascular access. I'm only talking about incident right now. And what they are saying is that we suggest, not prefer, not recommend, we suggest AV access rather than CVC. And they said it's a conditional low quality evidence. And then they went on to say that this is a decision between all of you and blah, blah, blah. But essentially what they ended up saying is that we don't have enough evidence to recommend this based on mortality or real hard, good quality outcome. And when you say mortality, you can again put in all of them together. Okay? What's the problem with that statement? They are now setting a standard for something which is not happening. I don't know whether you guys remember or not, in somewhere around 5 or 6 years back, we did. Now, how do you document that you've done SDM, shared decision making with patient? Well, there is no code for SDM, so there is no way to find this in how many people it is happening. It just all of us believe we talk to our patient fantastic. Ask me, I've been talking to people for many, many years. So we went and asked patients, hey, have you had any SDM about dialysis? Okay. And so this is our data. Dr. Chamathi actually was the one who wrote the first paper. One of our team members wrote the second paper. But essentially, this is the data out of somewhere around 1,800 people in 6 states. Okay. We had to categorize. How do we evaluate this? So we categorize it by saying that if you have advanced CKD and you don't see nephrologist, you have a level 1 care. You see nephrologist, that level 2 care. If you remember your nephrologist talking about dialysis, that's level 3 care. And if you attended a dedicated class, that's level 4 care. Okay, I don't know whether that's good or not, but I think that's real good jumps. Because eventually what matters is what patient remembers. So about 10% get tier 4 care, about 15% don't get any care, or 10%, and the rest of them are evenly split in remembering whether the nephrologist ever talked to them about dialysis or not. This is our SDM for dialysis modality. Extend this to vascular access, and you realize there is no SDM happening. So I'm not sure when they said in these guidelines, do plan, and they provide a template, who are they targeting? It requires, again, a new effort for quality improvement to actually implement it. And then what happened? these discussions have already started negative connotation about fistula. So this is a study that was published last year. Between 2015 to 2020, our incident fistula rate went up by 30%. And our incident CVC rate this is a sort of order of incident CVC, went up by 70%. The crude rates are on that side. So in last few years, we actually have a reversal of what we have been trying to do. So either we were doing terribly wrong before, or we are doing something which doesn't make sense. And I don't know, as a person who does SDM all day long, most of the time, I don't know when they tell me do shared decision making, but there is no clear evidence which says what is better versus worse. In dialysis, there is enough lifestyle differences and enough knowledge or awareness around that I can do some SDM. In fistula, if you don't tell me which one is better or what is the inclination, if the recommendations are so loose, how am I going to do SDM? So basically, in order for me to do SDM, I need to inform patient of something, but I can't really do that unless, now by I mean not the people in room here, you guys study a lot, you guys do a lot, but a guy in Timbuktu, he's taking care of 6 hospitals, this, and he doesn't know or she doesn't know that what SDM means unless you tell them that, hey, this is better or this is how you do it. Anyway. So the problem with the current strategy is this, that guidelines recommend SDM, but we don't have a way to figure out SDM, okay? There is a quality of care, but we really don't have a marker for good quality of care. There is a vascular access, which we always talk about, incident vascular access. The vascular access comes, goes. So the impact of vascular access is actually time varying. Some days the patient has vascular access, some days they don't. So that's a different measure. There are no methodological advances. Epidemiological studies just continue to give us, hey, you got exposed to this, that's the outcome, that's what happened. There are only 2 time point, exposure and what went into outcome. And the guidelines do not truly adjust for comorbidity. So we thought we can advance this a little bit. So this last 10 minutes or 15 minutes, we are going to do this slightly differently. It does look like that I talked a lot. So I probably will skip you.
Okay.
You are there for answers. Thank you so much. So we said we will try and address this, okay? It's somewhat, whatever we can. And we have to avoid the problems of the previous analysis. So we'll say we can use actual education as a surrogate for SDM. So we can do this in the current paper that we can do pre-dialysis nephrology care as a quality of care. There is no universal marker. The only thing that has consistently shown some of the largest benefit on post-ESRD mortality is pre-dialysis nephrology care. We are that good. Maybe we can use that as a marker. And then we can use longitudinal evaluation to see whether we can dissect not just some random association, but where this happens, okay? So a simplified model is, and then we can have these 2 things, but at least what I'm about to show you won't have those last 2 problems corrected. So my simplified model is going to be this, which said in different word is, oh, no, don't do that. This is twice. Okay, so my simplified model, you guys have seen this model, this thing. So exposure is pre-dialysis nephrology care, which takes into account whatever happened before dialysis. Mediator is incident vascular access, outcome is survival. It takes into account the longitudinal care. Now, this is where I'm supposed to hand over to Nicole, but looking at time, I'm not going to do that. So these are the things that we are going to avoid. But Nicole is here, so she'll be able to answer all the questions. But I was supposed to recap what she spoke in one slide, and this is my next slide. In order to do this analysis, this continuous event analysis, you have to have mediation analysis. You have to have these 4 conditions satisfied. One is you have to believe that exposure, and I'm going to say 3, exposure affects mediator, exposure affects outcome, and mediator affects outcome. Meaning thereby, pre-dialysis, and when I say this, just see it in your head, whether you agree with it. Pre-dialysis nephrology care can improve incident vascular access rate. Pre-dialysis nephrology care can improve survival on dialysis. And based on what I have shown, vascular access can influence survival. If you agree with these 3, we can go with this. The 4th condition is my mediator has to be in the middle of the 2, meaning thereby I can't use vascular access as an exposure, pre-dialysis care as a mediator. It has to be in a chronological event. The event 1 has to happen 1, 2, and 3. Okay? That's what we satisfy here, and that's how we are going to do. This is the same thing said in a figure form. This was a 2017 CJSON publication, so I just put it there, but essentially I'm saying the same thing. Okay, let me go one by one. This is a USRDS analysis between 2010 and 2009 and 19, or 10 and 19, and about 400,000 incident ESRD patient, hemodialysis patient, okay? Give or take. First, we are going to examine the pre-dialysis nephrology care to vascular access outcome association, simple. What we are finding is, if you have pre-dialysis nephrology care, you have 10-fold higher, 10 times the odds of having incident vascular access, AVF or AVG. The other colors are for longer duration of pre-dialysis nephrology care, meaning thereby, if you have more than 6 months of pre-dialysis nephrology care, you have about 13 times. And if you have more than 12 months of pre-dialysis nephrology care, you have about 16 times higher chances of having vascular access. You also have somewhere in the vicinity of 2 to 3 times higher chances of having maturing vascular access. You still have CVC, but you have maturing vascular access. And then you have 75% lower, and there is no way I could have demonstrated this unless I created a logarithmic scale on this side, but those odds ratios are in the vicinity of, so you have about 80 to 85% lower chances of doing central catheter, okay? Just remember the effect size here, 80% lower chances, it will come back. This is what happens to the mortality. Yes.
Quick question about these 3 groups. What are the numbers in them? They're kind of pretty much the same number, or they're much the number in the list. Any pre-dialysis would be much more than the other one.
So the general dictum here is that there are 4 categories. I haven't put the 4th one here, 0 to 6 months, but each one roughly has a quarter of USRDS population, give or take. Okay. Is that reasonable? Like, I mean, there is a little bit up and down there. So,
I have a question.
So these are large samples, essentially.
So the upper numbers, the 0.17, 0.2, 0.23, on the upper side, under adjusted odds ratio, I can see that the upper border of the confidence interval is coincident with the point estimate itself.
Yes,
so
because it's a
0.17.
very large sample size, so the confidence is very good. Like,
right, like it's 0.17, 0.17. Yeah.
So it's like what it essentially means when your 95% confidence interval goes so narrow, that means you are very certain of your analysis, very certain of your point estimate.
The other is, it's your very sample size. You might be seeing a lot of positive things that will be negative in a smaller sample size. That's another argument, is what we call overpowering of the study.
Correct, absolutely.
So that can be the argument, is if you're overpowered, sometimes even if it's negative, it will be positive. So that's another positive,
That agreed. If this reach somewhere close to 0.99, I would agree with that conclusion.
Mm-hmm.
That, if you have 0.98 and 0.97 and 99 is your thing, it's very difficult to say that your reduction of 2% is really, you have that much power, even if you can overpower that by numbers.
That's why I think that question about the N is very important.
So the N is somewhere in the vicinity of 80,000 to 100,000 for all of this. But this would be less of a problem at 0.17. 0.17, you are so far from 1 that you are actually demonstrating a strong and a very homogeneous effect here. I would say this. Okay, anyway. Then go to the vascular access. Okay, so this red line is what you see in all studies so far. AVF, AVG are associated somewhere between 54 to 37% mortality risk reduction over 1 to 5 years. We have examined this in 3 vantage points: 1 year, 3 year, 5 year. Okay, this is what the conventional studies report. This is what our analysis I showed you before reports. As soon as you put pre-dialysis quality of care by the surrogate of this thing, what we are showing is the actual, once you include pre-dialysis care, the actual benefit of with that, the hazard ratio goes down tremendously. Meaning thereby, when you assess the vascular access, you have a lot of quality of care noise, which you can clear up by this. Again, we don't have an ideal measure for pre-dialysis quality of care. So we are not saying that's what it's accounting for all of it. But as you can see, it moves substantially. This part is if you didn't have vascular access, this particular vascular access, what would have happened to mortality? What your current data shows in that population for mortality, control for everything else. And so what this is showing is that about half to 3/4 of the survival advantage associated with pre-dialysis care is mediated through vascular access. Does it make sense? It's not that vascular access improves mortality by this much. No, about half to 3/4 of what you get from what your care to patient is coming through your planning of vascular access. Okay.
Now,
Okay.
does this account for the equivalence of having vascular access, meaning these were healthier patients compared who did not, to those who did not get vascular access?
Right. So the baseline at which we start here, and the baseline for this and all of these analysis is the accepted model of comorbidity profile are all adjusted for. So these are not unadjusted. Every single analysis I'll give you is all adjusted. The unadjusted are all congruent to this, but I'm not showing you those things. You see my point? Okay. The same thing if you go for graft. Graft, again, if you see epidemiological study, it shows that they are somewhere around 37 to 25% reduction in mortality. This is not graft, sorry. Maturing AVF, AVG, not graft. Graft was included in the previous one. Maturing AVF, AVG. They have lower hazard, or lower quote unquote association of benefit. Again, about 1/4 to half of all of the benefit, which is an intermediate mediator, are mediated through this thing. Finally, I think this is interesting. This is CVC versus everything else. And I think it took me a lot of time to understand this, so please bear with me. On its own, CVC is associated with substantial increase in mortality, right? We all know this. When you see nephrology care, in context of nephrology care, if you provide nephrology care and CVC included together, 25% lower mortality. So you are now comparing like to like people, right? Or something of that nature. Your selection of your intervention of CVC, meaning thereby we saw that it reduces, you reduce CVC use by about 80%. That reduction by 80%, your intervention as CVC improves mortality by about 46 to 70%. What essentially it shows is, and at least this is where I am sort of going, there are still more analysis being done. What I'm thinking is happening here, that as a nephrologist, we are able to dissect who goes where And that movement of that CVC that you produce, lower CVC, that means higher AVF, AVG, actually attributes to survival advantage. What is the end result of this? What am I trying to do here? Well, I'm trying to actually figure out that in this current recommendation of shared decision making, where I'm supposed to go and talk to a patient, what am I supposed to talk? Am I just saying, hey, this looks this looks this looks this, tell me what you want to do? Or can I have a reasonable way to say, there may be a benefit on X, Y, Z. I showed you mortality. The same analysis can be done for infection, hospitalization, all of these, okay? What do I do? And that's what I'm trying to say. And I believe, considering what the paper that I showed you with recent reversal, I believe that current guidelines have gone a little bit too much on the other side without providing clear guidance as to how this is supposed to be titrated. Anyway, summary. This is the problem for us, the summary statement 1 and 2. There is a reasonable expectation that most patients should have AV access. And we do this day in, day out in our hemodialysis unit. So the question is not, should we recommend AVF or AVG or not? Because if that was the question, you wouldn't do that in your dialysis unit. You would have to recommend, because there is, apparently we are doing it. So I'm not asking that question. If somebody wants to argue, figure out how to deal with that problem. The question currently appears to be, if we are doing this day in, day out on dialysis patient, should I do it before dialysis, or is there a way to do it? And I think that our findings suggest that there may be a protective effect, that the original hypothesis that improvement in quality improves vascular access and improves survival, it's still true. It just is not dissectable within the current evidence. And as such, the guidelines should not have gone that dilute. Summary 2 is, guidelines recommend shared decision making for these people. We need more studies to figure out who are these people in whom you need to have diluted guideline, and who are these people in whom you need to have a stronger guideline. Your guidelines currently are just lumped together. We need comorbidity adjusted. And how do we achieve shared decision if we don't know the true influence? As a physician, you tell Cytoxan versus Rituxan all the time. But you have to know which one of the two is better, or on efficacy, lifestyle, or something. Otherwise, you can't just decide. Otherwise, you are the one taking decision. And then finally, I think it appears reasonable to state that epidemiological analysis likely overestimate the association between incident vascular access and mortality, and by extension, most other complication. And we think that our analysis at least is punching a small hole in this, saying that this is a little bit going on the other side too much. There are a bunch of limitations and so on and so forth. So I'm going to stop. Sorry, I went all the way to a few minutes remaining. Any question, I'm happy to answer with this.
I have another question. So if
Please.
the duration of prior nephrology care has an effect on the ultimate outcome of the mortality towards the end.
So the same thing that I showed you was for the primary analysis of, and this is what Nicole would have covered, primary analysis of any nephrology care. With duration of nephrology care, we show maintaining of these effects, or maintaining of this and slightly stronger protective effect of nephrology care.
Is there any hard number on that duration? How many years, months prior to?
Remember the USRDS, this is actually what you're asking is a great question. What is the duration of pre-dialysis nephrology care? And actually, when we do these studies, they always ask us, hey, you are writing, and my studies are in CKD, and they are asked, how do you decide duration of advanced CKD care? Half of them can't remember which doctor they saw.
Because
right?
arguably before we get aligned, there is some kind of nephrologist preparing them. And that 1 week that you saw, is that nephrology care counting towards somebody who's been seeing somebody when they still see 3 days before? And that duration, does it affect the outcome?
Yeah, I think you're absolutely correct. The problem in these analysis is, this USRDS analysis is, that these are self-reported variables, and this is where it's going to say. The problem for all of us to say on the flip side is, we are never doing a randomized control trial on this. At least not that I can clearly see. I don't see anybody coming up to do a randomized control trial between fistula and CVC. So what are we going to do? we still have to find out the truth because there is no RCT happening right now.
Yeah, in effect, this is just a parallel of what's going on with transplantation.
I know,
There's
I
a
know.
lot of selection, there's a lot of
Yeah.
normalization. We're just making conclusions that it's
It's associated with, but just we're going just for the take off for the fellows.
So
Doesn't affect it. It's associated with their outcomes.
So you have to remember, what we are showing is pre-dialysis care is associated with improved survival, but the vascular access attributes to that association. So the protective effect of vascular access is on that association. So the causality or causal mediation, this is why we only say that we are only reporting association at the end of the day, not causality. But yes, I think you have a point, and that's a very good point. This is at the end of the day an analysis of our practice biases as much as you can dissect, not the actual randomized control trial.
That was perfect. Thank you so very much.
Thank you.
Happy birthday
To you, always your birthday.
Happy birthday to you. Happy birthday.